Good evening to everyone present here with us today. This is Sriyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. H. Krishnamurthy. Sir is the head of Department of Urology of Lourdes Hospital, Kochi. Now, with the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is BPH, the new era of medical optimization. Now, without any further delay, I would like to hand over the session to Sir so that he can begin with his precious talk. Over to you, Sir.
Thank you very much. First of all, I thank the IJCP group for inviting me to this platform to share my thoughts on the medical management of BPH. BPH, we know, is benign prostatic hyperplasia, which is a very common disease that occurs in the male population after the age of 50 or 55. Around 40 or 50 years back, this disease was considered dreaded because the treatment was just surgery. It was a frightening surgery with so much of blood shedding that we used to lose many patients on the table. So people were afraid of this disease, considering the treatment that was available, which was nothing but surgery. But over the period of time, the management has changed. Newer and newer molecules came in, newer and newer chemicals came in, and we slowly shifted ourselves from the surgical side to the medical management. So much so that we have an array of medicines which are available now for the treatment of this disease. So it is only pertinent, especially because we are celebrating the Prostate Health Month during this November, to discuss on the optimization of medical management of BPH. I bring greetings from Cochin, and with this introduction, we go to the topic proper. Now, the topic, for ease of understanding, has been divided into two. First part deals with the BPH per se, how it happens, what are the mechanisms, and the basics. Followed by the second part, wherein we embark on the medical management, and to end up the show, we will tell you how to optimize the treatment so that we can have a take-home message from this talk. Now, BPH, as we said, is benign prostatic hyperplasia. It's not hypertrophy, it is hyperplasia. There is an increase in the number of cells. It's one of the commonest causes of lower urinary tract symptoms. Previously used to be wrongly referred to as prostatism. There is an increase in cell number. Cell number means the epithelial cells can proliferate, the stromal cells can proliferate, and there is an impaired programmed cell death. This is called as apoptosis. This word we'll keep on using because some of the drugs act on these mechanisms. So on one side, when the cells proliferate, on the other side, the cells die. There should be a balance between the two so that the prostate maintains its growth or it becomes static. If there is a decrease in the death of cells, then probably there is a hyperplasia. And the other way around, when the cell proliferation reduces and the death increases, the organ goes in for atrophy. 50% of the men have pathological BPH. Why we said pathological is because every man has some sort of, even a bit of prostatic hyperplasia in him. We are bothered about only pathological BPH. That is symptomatic BPH or BPH that requires medical management or a clinical addressing. 50% of the men at the age of 50 years have pathological BPH, which increases to 90% at the age of 90 years. So you know that every 10 years there is a growth of 10%. But if you see the doubling time of the hyperplasia of prostate, we'll see that between the age of 30 and 50, the doubling time is 4.5 years. That is, it doubles its size very fast. And when you look at the age over the age of 70 years, the doubling time is more than 100 years. So that means as age goes on, the doubling time or the enlargement of the prostate rate actually comes down. This is very important for the management of this disease. So, younger the age, more is the growth of prostate. Now, etiology, we all know that prostate is a androgen dependent or male hormone dependent organ. Androgens are necessary for the development of the BPH, but it's a curiosity to know that as one grows older, the androgen level, the peripheral androgen level or the testosterone level actually comes down. Then why prostate alone develop? This is because the testosterone or the androgen gets converted into dihydrotestosterone. This occurs in the presence of the enzyme called 5-alpha reductase. 5-alpha reductase type 2 is there in the prostate, type 1 is there in various other organs, which we are not very much interested about. Androgen receptors actually increase with aging inside the prostate, but not outside. Only in the prostatic organ, the androgen receptors increase as well as they maintain their response to the circulating androgens. Androgen receptors increase in number and increase in sensitivity. Now, what happens to the estrogens? Estrogens, we know that there is an increase in estrogen that occurs as a male grows older. And this estrogen sensitizes the prostate to the effects of androgen. So it has a permissive effect on the effect of androgen on the prostate. But the current theory is that growth factors in the form of fibrin growth factor, epidermal growth factor, transforming growth factor, and insulin-like growth factor, so many of them, cytokines, are responsible for the prostate growth, which gets mediated by the androgen receptors. So it ultimately rests on the growth factors to decide whether the patient is going in for BPH or not. Genetic factors do play a role. Autosomal dominant is the character that occurs for the development of BPH. So, if in the family there is an increase in early incidence of BPH, it's likely that you are to get an early BPH. So, it's an autosomal dominant trait. Now, coming to the anatomy of prostate, the classical lobes are the middle lobe or the median lobe and the lateral lobes, which is no more pertinent. We have the physiological lobes or the zones decided by John McNeil. Why he attributed zones to the prostate is because of the difference in the pathology. There is a peripheral zone, there is a central zone, transitional zone, and a periurethral zone. The transitional zone is where the BPH develops, whereas the peripheral zone is prone to develop carcinomas. So, depending on the zone, the type of the disease in the prostate varies. Coming to the pathophysiology, we know that at the age of 30 years, the prostate starts growing in. Small micronodules start developing in the stroma. And as one gets older, the micronodules slowly increase in size to form macronodules and then pathological BPH. And once the pathological BPH comes in, you have the clinical BPH wherein the symptoms manifest. So there are two aspects of prostate which can produce obstruction to the urinary flow. One is the mechanical or the static or the passive obstruction. This is because of the mass of the prostate. A larger prostate, which is sitting just below the bladder, surrounding the urethra, can produce mechanical obstruction. Now you take the other component, the dynamic or the active component. Alpha 1 receptors, particularly the alpha 1A, are there in the prostatic stroma as well as some of the beta 1 is actually in the epithelium. They are also there in the prostatic capsule. And mind you, these alpha receptors, when get stimulated, can produce contraction. That can also produce obstruction to the urine flow, which is called as a dynamic obstruction. So we do not know how much of the static component is responsible or the dynamic component which is responsible. So that's why we say that the size of the prostate measured by its anatomical volume is unrelated to the degree of symptoms. Depends on the percentage of mechanical or dynamic obstruction that contributes to the pathology. So you have a smaller gland on your left side and you have a larger gland on the right side. Though it is smaller gland, the symptoms are more probably because the dynamic component is much more in this patient. In the other one, it's the mechanical component that is more important. So that can vary. So we do not know how much of obstruction each prostate can give rise to because there is no measure of the dynamic component. It's only a presumption. Now, in addition to the static and mechanical components, wherein we said the volume of the prostate as well as the alpha adrenergic stimulation, which are important, you have the autonomic overactivity. An overstrung person or a dynamic person, younger person, high strung person who is autonomically overactive, it can lead to an increase in smooth muscle tone and proliferation. So autonomic overactivity can give rise to more of dynamic obstruction. Inflammations can activate Rho kinase, which is another mechanism for the symptoms of prostate to precipitate. That can also lead to smooth muscle cell proliferation as well as smooth muscle tone. Now, as one grows older, the nitric oxide mechanism also comes into play. When there is a reduction in the pelvic nitric oxide, this again contributes to increase in smooth muscle tone and activity. And finally, atherosclerosis or pelvic ischemia can stimulate hypoxia-inducible factor, which in turn acts on the the fibrin degradation, the fibrin factor, fibroblast factor, and that can also cause dynamic obstruction. So all these can also contribute to the dynamic component of the prostatic obstruction. So this happens when one grows older. So you know that it is not entirely dependent on the androgen levels and DST level. There are various mechanisms that come into play as a male grows older to produce the symptoms which are relevant for management. Now, if you look at the distribution of alpha receptors, there are three types of alpha receptors, alpha 1A, D, and B. C is not there. Alpha 1A is the one which is important for us because they are concentrated on the prostatic smooth muscles and capsule. It's there in the stroma and capsule. Whereas alpha 1D is there in the bladder. And there is a possible role of this in bladder activity. This is important to know because the drugs can have specific effect on this. So alpha 1A when stimulated produces contraction of the smooth muscles, so the urine flow gets affected, and alpha 1D produces detrusor muscle contraction, which aids in urine flow. Alpha 1B is more there in the vascular systems, there in the myocardium as well as the vascular muscles. And of late, it has been diagnosed that there is an increase in alpha 1B activity in the prostatic epithelial cells. This is important in the case of prostate cancers. So in prostate cancers, probably alpha 1B is more in number in the prostate. The symptoms of BPH, we all know, is narrow and interrupted stream. The stream gets broken in between. There is a hesitancy, there is a difficulty to start urination. Frequency is there, urgency. The patient has an urgency to pass urine. He rushes to the toilet, but the urine comes out, leading to incontinence. Nocturia, that means he gets up frequently in the night because the voiding is not complete. Dysuria, that is painful micturition. And symptoms related to the complications of BPH. So these are the symptoms. So we basically classify them into storage symptoms and voiding symptoms. Voiding symptoms previously called as micturition symptoms, wherein the flow gets affected. Storage symptoms means there is an increase in frequency and nocturia. So irritative symptoms. So these two are the two classes of symptoms in BPH, which we'll have to assess when we treat a patient with BPH, because the treatment can vary in these two situations. Lower urinary tract symptoms, bladder outlet obstruction, benign prostatic enlargement, all are having overlapping symptoms. One is used in certain set of people, while the other terminology is used in other patients, but basically all of them produce obstruction to the urinary flow leading to symptoms. Now, what happens when there is an obstruction to the urine flow? The bladder tries to push out the urine through an area of obstruction, which leads to smooth muscle hypertrophy in the bladder wall. Slowly, there is a loss of bladder compliance, because once the smooth muscle starts contracting against resistance and nothing happens, the pressure gets transmitted to the kidney. The kidney is going for failure. But after some time, the bladder knows that it is not going to work, and it goes in for a stage of detrusor, low detrusor contractile or underactive bladder, or terminal bladder, or end stage bladder. Trabeculations and saculations occur in between areas of collagen deposition. They all indicate that the bladder is having very high pressure to push out urine. So the bladder wall thickens. Initially, unstable contractions occur, and gradually it goes for myogenic failure. So that is a sequence of events that can occur in the bladder when the patient has an untreated obstruction to the urinary flow. Etiology of BPH, nobody knows why it happens and what can precipitate it. Some generalizations can be made, like Jews are prone for BPH for reasons unknown. High sexual activity can lead to an increase in stromal component, but again controversial. Alcohol can reduce the androgen and the prostate growth. So the symptoms of BPH are going to be less if you're a chronic alcoholic. That doesn't mean that we'll have to drink alcohol. Smoking increases the testosterone levels and probably contributes to the symptoms of prostate. And obesity. What happens in obesity is the adipose tissue, which is more, converts the testosterone to estrogen. So in the initial stage, more and more testosterone gets lost. So the size of the prostate decreases. But after some time, the estrogen itself can act as a permissive, can give a permissive role in the development of prostate. And some of the medications, like especially the cough syrups, antidepressants, and antihistaminics, can all aggravate the symptoms because they also act on alpha-1 receptors. So the dynamic component is aggravated by your concomitant medication. So nobody is sure why prostate develops in some of these patients and which one is protective. So it is a disease which can happen in any person at any point of time. Complications of BPH, because the urine gets stored for a longer time, not completely getting emptied, can lead to recurrent UTI, bladder decompensation. Bladder stones can develop because of recurrent infection. And gradually, we said, when the bladder pressure goes up, the kidney pressure also goes up, and that leads to kidney failure. So the microvascular density, more and more vascularity occurs and leads to hematuria. Ultimately, the patient will not be able to pass urine, which we call as acute urinary retention. There are three types of acute urinary retention. One is the spontaneous AUR, wherein in the course of urinary obstruction, wherein the patient is going for a urinary obstruction, some factors like an excess fluid intake, alcoholism, sex or bed rest, or prostatic infarction can aggravate the symptoms and lead to spontaneous AUR. So spontaneous acute urinary retention means the patient, over a period of time, the symptoms were worsening, and one fine morning went into retention because of added factors. Precipitated AUR means it is triggered by a non-prostatic event like a surgery. You have a pile surgery or a hernia surgery, and catheterizations, anesthesia can all lead to precipitated urinary retention. So this is not very important because precipitated retention is treatable. It is not because of the prostate. It is because of something else which has precipitated urinary retention in the person. Refractory retention. In a precipitated retention, you remove the catheter and see whether the patient voids. And if it doesn't void, even after one attempt of catheter removal, that is called as refractory retention. So we are bothered about only the spontaneous retention as well as the refractory retention. Both will require some form of intervention. Diagnosis of BPH, we said history taking is very important to rule out any other causes of urinary obstruction, like strictures or stones in the urethra or previous surgery or anything of that sort. IPSS score is International Prostate Symptom Score, which is otherwise called as an AUA score. The IPSS has a quality of life index also, wherein you ask the question, a set of questions to the patients, and he says over the last 2 weeks how much of symptoms he had. And based on which we score these patients, whether it is 7, 8 to 19 or more than 19. And we classify them as patients who have mild, moderate, and severe symptoms. Digital rectal examination to assess the prostate volume. We said it can only assess the static component. The dynamic component cannot be measured by your DRE, but it will detect malignancy if it is there. Urine test to identify the presence of urinary infection. Renal function test to assess kidney function. And PSA. PSA is a marker for prostate cancer. It's very controversial whether we should do PSA in all patients who have symptoms of prostate. Probably the generalization would be do it in patients in whom the identification of prostate cancer will help you to decide the treatment on this patient. Because if the patient is quite elderly, after the age of 80 or so, even identification of prostate cancer is not going to be important because we are going to observe the patient. So do PSA in younger patients and especially those who have a family history of prostate cancer. Uroflowmetry, wherein you measure the flow of, it's an objective assessment of the flow of urine. Subjective is the one which the patient says. Objective is one what we measure. And if the maximum flow rate is more than 15, then it is probably the person is normal. If it is less than 10, there is obstruction. But it has a lot of fallacies. Post-void residue is something which we measure in our ultrasound. That is the amount of urine that is getting collected. Again, it has a lot of pitfalls and individual variability. So probably one generalization what you can say is if the post-void residue is more than 100 ml repeatedly, then probably the patient is not suitable for medical management. Urodynamic studies wherein you measure the bladder dynamics or the bladder pressure to identify how much pressure the bladder develops, whether it is hyperreflexic or underactive bladder. And that too, we don't do it regularly unless you have a patient wherein the surgery has failed or a young patient or the symptoms are totally different. We are from the classical symptoms of BPH, wherein we suspect something else like a neurogenic bladder to identify the cause and the pressure in the bladder. We do urodynamics, not routinely done. Cystoscopy, wherein you put in your endoscope through the urethra and identify how much of obstruction the prostate gives. This again we said can measure only the static component. The dynamic component cannot be measured, but coexistent problems like the patient has a stricture or a bladder stone can all be identified. This especially we do if the patient has undergone prior lower tract surgery to identify any strictures that are developing. And again, there is no relation between the endoscopic appearance of the prostate and the treatment outcome or the treatment, the symptomatology. Imaging, we do only in cases of renal failure as well as in cases of hematuria, history of stones, and previous surgery. We don't do it routinely. So that is the first part of the talk, wherein we said prostate is a hormone sensitive organ, Mainly, it is dependent on androgens. Though the peripheral androgen decreases, the intraprostatic androgen and androgen receptors increase in number and maintain the sensitivity to androgens. There is a static component contributed by the epithelium and stroma, the mechanical component, and there is a dynamic component which is contributed by the alpha receptor activity. Alpha 1A is more there in the outlet, in the bladder neck as well as prostatic capsule and in the prostatic stroma, whereas alpha 1D is there in the detrusor, in the bladder. Alpha 1B is not important for us because it is mainly in the myocardium and the peripheral vascular circulation. And there are various other factors like nitric oxide mechanism and atherosclerosis that can also contribute to the genesis of symptoms of prostate. And how we assess the prostate, mainly the IPS score, and an array of tests to identify how much of obstruction the patient has and whether it is entirely because of prostate. Now, once we have come to the diagnosis of BPH, we have ruled out various other causes of urinary obstruction. We go to the management. That is the second part of it, which is the one which we are going to discuss today, which is the one which we are supposed to discuss today and highlight upon. Number one is prevent BPH. The management can vary from preventing BPH to the surgery. You have watchful waiting in between, you have alpha blockers, anti-androgens, phytotherapy, a lot of things are that are coming in, which may be suitable in certain number of people. Now we go to one by one. Now, when we look at this, the pie diagram, we know that in 1992, as we said, the surgery was being done in about 50% of patients. It's slowly coming down, and surgery is getting confined to 10%, now even less than 2% of cases. So that means the medical management of BPH is very, very good these days with the availability of potent drugs. Now, can we prevent BPH? The answer would be no, because every male is at risk of BPH. But the only generalization that can be made is men with large prostates are at greater risk of developing urinary retention. That's the only generalization that can be made. You do not know which person is going to have symptomatic BPH. So, preventing BPH is a myth. Watchful waiting, yes, you can observe some of these patients who have mild symptoms and will not have irreversible consequences. So what you do is you ask them to reduce the fluid intake. You ask them to reduce alcohol and caffeine intake, especially in the evening and night time, and keep a time voiding schedule wherein the patient can understand when and why he is putting out excess of urine and he can control himself. So it's a sort of self-control or a feedback mechanism for the patient himself. So these are the types of the measures which you can tell a patient who has mild symptoms, where he can do an adjustment in his life pattern and reduce the symptoms of prostate. This is watchful waiting. We don't do anything for the prostate at all. Now we go to the first class of drugs, the first group of drugs, which are alpha-adrenergic blockers. As expected, these drugs act on the dynamic component. So we said it is the alpha blockers which produce the dynamic component. So you have alpha blockers which are available. Alpha receptors, when get stimulated, produce the symptoms. So you have alpha blockers which will reduce the symptoms. Now, alpha 1 selective are prazosin, alphazocin, doramine. Now, since it is non-selective alpha 1, it can act on alpha 1A, alpha 1B. Alpha 1B is there in the vascular smooth muscle, so the symptoms are going to be, the side effects are going to be more. These are all short-acting drugs, so you have the long-acting drugs like the terazocin, doxazocin that have come in, which will have a non-specific effect on the alpha receptors, alpha 1A and B, but they have longer duration. And then the uroselective ones, that is alpha 1A selective drugs, tamsulosin and silodosin. We'll go to each one of them in detail. Prazosin is a non-specific alpha 1 receptor blocker. It is a very highly potent antihypertensive. It is very short-acting, so you have XL preparations or long-acting preparations which are available, and has got mild effect on BPH. So you have a patient who is on prazosin, has mild symptoms of BPH. This is going to be effective. So we go to the longer acting drugs, longer acting non-specific alpha blockers. One is the terazosin. Terazosin is probably the most investigated alpha-1 blocker. It came long time back and it improves all the symptoms. Theoretically, it should act on the dynamic component, but it does act on the static component as well. And what about its effect on BP? It significantly lowers BP only if the hypertension was poorly controlled. If the hypertension was well controlled, the decrease in BP is not going to be that much. So you can safely give to a patient who is not very hypertensive but has symptoms of BPH. Now, when we look at the homeostasis, or prostate gland homeostasis, we said there is apoptosis. There is cell multiplication occurring on one side and cell death occurring on the other side. And there is a balance between the two. And this particular molecule, terazosin, what it does is it initiates apoptosis. So it stimulates apoptosis. So the cell death is stimulated by your terazosin. So what happens is, we'll go to it. It induces the apoptosis. It occurs through an alpha-1 independent mechanism. It is not through its alpha-1 A or alpha-1, general alpha-1 action. It involves a tumor growth factor or transforming growth factor, and it produces a particular function called as anoikis. That is, it disrupts the cell from the extracellular matrix. So these are different mechanisms which are possessed by terazosin. So if there is an increase in apoptosis or programmed cell death, the prostate should not grow in number as well as size. So in short, it acts on the static component as well. So the dynamic component of the prostatism or the prostatic obstruction is taken care of by its alpha receptor blocker activity, and the static component is taken care of by the induction of apoptosis by terazosin. So this we said, there is a reduction in stromal smooth muscles and the BPS symptoms comes down. So over a period of time, the symptoms of prostate comes down, both the dynamic as well as the static components. And why this is specific for terazosin is because of a particular part of the molecule, the chemical structure of the molecule, which is called as a quinazoline ring. This quinazoline ring is responsible for inducing apoptosis. And this is there to a certain extent with doxazosin, but not there with tamsulosin. So terazosin may be very effective to reduce both static and dynamic components of the prostate. Coming to doxazosin, it is less effective than terazosin, and the systolic BP changes in normotensives are greater. We said if you give terazosin to a normotensive patient with BPH, the decrease in BP is not going to be very high. But here, doxazosin is mainly an antihypertensive drug. So the reduction in BP is going to be high. So the patient can have dizziness, fatigue, headache, somnolence, etc., etc. But fortunately, we have 30% of men undergoing treatment for BPH who have coexistent hypertension. So this may be a drug wherein the patient has both hypertension and BPH. Now we come to tamsulosin and alfuzosin. Tamsulosin is an alpha-1A receptor blocker. Alfuzosin is just alpha-1 blocker. Why we include it as uroselective is because the side effects of alfuzosin is same or less than that of tamsulosin. Though its effect is different, side effects in the urinary system are less with alfuzosin. So we consider alfuzosin as also a uroselective drug. Since it acts on alpha-1A receptors, which are there in the outlet, in the prostate capsule as well as stroma, they do not affect the BP. To affect the BP, it should act on alpha-1B. Dose titration is not required. So the dizziness, asthenia, and dizziness is less there. Postural hypertension is less. Probably the first dose or the second dose can produce a little bit of postural hypertension. But the other symptoms like rhinitis, stuffy nose, asthenia, and ejaculation, this is because of the inhibition of serotonin. It does not affect the libido, it does not produce erectile dysfunction, it produces ejaculatory dysfunction. And it produces intraoperative floppy iris syndrome. That means if the patient is going to have a cataract surgery, they are going to have some difficulty in dilating the iris. So the drugs will have to be stopped. It is specifically there for tamsulosin, less there for other drugs. So the drug will have to be stopped at least 3 months prior to the patient undergoing cataract surgery. So since these alpha 1A receptor blockers act specifically in the outlet, they can be combined with antihypertensives. They can be combined with PDE5 inhibitors for your erectile dysfunction. And their effects on cardiovascular system, as expected, is going to be much less compared to terazosin, doxazosin. They will not have any effect on the erectile function, but ejaculatory function will be affected because of the inhibition of serotonin. Naftopidil is a drug which has not become very popular. It acts on the alpha 1D receptors. We said alpha 1D are there in the bladder, which is necessary for bladder contraction. So if it can act on the alpha 1D, probably the contraction of the bladder can be prevented. The irritative symptoms of the storage symptoms can be taken care of by this drug. So though the outlet is not affected, the bladder functions are affected by naftopidil. So probably that is the reason why you are not going into the exact mechanism of urinary obstruction produced by the BPH. By your medical management with naftopidil, naftopidil did not become very popular. And when you look at naftopidil, it gets absorbed very fast. It has a very long half-life of around 20 hours. So it's a long-acting drug. But the problem is it gets excreted through your liver. So in liver dysfunction, this cannot be given, though it can be given in patients having renal failure. Silodosin is the next drug that came into the market. It is highly alpha-1A selective. Tamsulosin is also alpha-1A selective, but this is 38 times more. It has 38 times more affinity to the alpha-1A receptors compared to the tamsulosin. So it has a very fast action and very avid alpha-1A blocker. So it has a longer half-life also compared to tamsulosin. So the symptoms of prostate enlargement by the dynamic component gets alleviated very fast because the absorption is very fast. There's a long half-life. You have something called as the first dose effect. Even the first dose of silodosin can have a little bit of effect on the symptoms of prostate due to the dynamic component. Since it has greater affinity, the effects are going to be greater. So you can give it to a patient wherein your tamsulosin is not working because you have advantage of silodosin acting more on the alpha-1A receptors. You can also combine silodosin with sildenafil or tadalafil because it does not have any effect on the erectile dysfunction. So you can easily combine with other PDE5 inhibitors. And we said the fastest symptom resolution with the first day, first dose phenomenon. So if you want to have a faster effect, more effect on a patient in whom your tamsulosin is not working, then probably silodosin will be the best drug. But it cannot be, it is also safer in patients having mild to moderate liver dysfunction and renal failure. So it does not affect the kidney function and the liver function. Now coming to the PDE5 inhibitors, how it acts. L-arginine is there in the blood, which gets converted into nitric oxide by nitric oxide synthase or synthetase, which are there in the endothelium. The nitric oxide converts ATP and GTP into cyclic GMP. And this cyclic GMP is the one which is responsible for cavernous smooth muscle relaxation. So the erection happens. It also acts on the blood vessels to dilate the blood vessels. It also acts on the prostate. We said the nitric oxide mechanism is important for the urine flow as well. And once the function of cyclic GMP goes off, once the erection is over, cyclic GMP gets converted into GMP by phosphodiesterase. Type 1 to 6 are available, of which 5 is more important, which are there in the platelets, lungs, cerebellum, spinal cord, skeleton. All over the body, this PDE5 are available. So if you have some mechanism by which your PDE5 can be blocked by PDE5 inhibitors, the cyclic GMB can accumulate for a longer time and a longer and better erection can happen. That is the principle of giving PDE5 inhibitors. Though we said PD or phosphodiesterase enzymes are there in various parts of the body, of late it has been found that PDE5, the PDE diesterase enzymes are there, PDE5 is there abundantly present in your urinary tract also. So this has led to the introduction of PDE5 inhibitors for the management of BPH. So PDE5 may be involved in the production of symptoms of prostate enlargement. So you have PDE5 inhibitors, of which sildenafil has a shorter duration of actions, tadalafil acts for a longer time. So it upregulates the nitric oxide mechanism, Rho kinase activity is taken care of, and the alpha adrenergic blockages. So tadalafil has a variety of effects on the urinary system, wherein the urinary obstruction gets relieved. It is a longer duration drug. It has a half-life of around 17.5 hours, so the effect can last for about 2 to 3 days. And generally, these PDE5 inhibitors can produce headache. This is applicable for tadalafil as well, but not very serious, but should not be given in patients taking nitrates for angina. Otherwise, it is safe even in cardiac patients. So, can you combine alpha blockers with tadalafil? The answer will be yes. If you are combining with tadalafil for improving the erectile dysfunction as well as erectile function, as well as having more effect on the urine flow, you can combine with alpha 1A. Alpha-isosin is not alpha 1A, though it has side effects similar to alpha 1A. So alpha-isosin, tamsulosin, and silodosin are the drugs with which you can combine tadalafil. Sildenafil may not be good because it is a very short-acting drug. So you have combinations available now. Now, can you combine with anticholinergics? Anticholinergics are drugs which relax the bladder. You can give naftripidil because it relaxes the bladder, alpha-1D inhibitor. It's actually a mild inhibitor. So you can give anticholinergics like solifenacin, which you can combine with your tamsulosin, silodosin, or mirabegron, which is a beta-3 agonist. That can also relax the bladder. So patients who have symptoms related to the bladder, like the storage symptoms or the irritative symptoms, they are better off if you combine these alpha-1A receptor blockers with your solifenacin or mirabegron. Combinations are available now. Now, coming to the next set of drugs, we are not bothered about GnRH analogs or progestational agents or anti-androgen. They're all for treatment of prostate cancer. Whereas the 5-alpha reductase inhibitors, we said 5-alpha reductase converts testosterone to dihydrotestosterone. Dihydrotestosterone is the one which stimulates the alpha receptors in the prostate and leads to the genesis of prostate, the mechanical obstruction. There are two types, finasteride and dutasteride, 5 milligram and 0.5 milligram respectively. Finasteride is a competitive inhibitor of 5-alpha reductase. So it reduces the acute urinary retention. It actually reduces the size of the prostate because of its effect on the epithelium as well as the stroma, more on the epithelium. And also reduces the vascularity. So once the vascularity comes down, the prostate growth also comes down. So by this dual mechanism, it reduces the size of the prostate. But as expected, the drug has to be given for a longer time, for about 6 months' time, to have a significant effect on reducing the volume of prostate or the prostatic mass or the static component. As expected, it can produce decreased libido because it has an effect on the testosterone, and ejaculatory disorders can also ensue when you give these 5-alpha reductase inhibitors in the form of finasteride. Dutasteride is a dual inhibitor, type 1 and type 2. Type 2 is the one which is there in the prostate. But why type 1? Because type 1 also increases when the patient has an underlying prostate cancer as well. So if we have a patient with underlying prostate cancer in an elderly man, dutasteride may be effective. Now, aromatase inhibitors, we use phytotherapy. There are saw palmetto extracts, there are African plum tree extracts, the cactus flowers, pumpkin seeds. These are all very popular for the treatment of prostate. And the symptoms produced by the prostate. They contain phytosterols and phytoestrogens and terpenoids. The active component is not known, though it is suggested that they have a variety of action. They inhibit the 5-alpha reductase, they have anti-inflammatory effect, they are alpha adrenergic blockers, they reduce the cholesterol, free radical scavengers. So all sorts of actions have been contributed to the phytosterols and phytoestrogens which are there in these plant products. Still they are efficacious and still they are popular in the market. So if you look at the algorithm, going back to all what we have said about the medical management, you take a history, digital rectal examination, and PSA if necessary. And then based on the IPS score, you classify them as mild, moderate, and severe. If it is mild, just leave the patient alone, have a watchful waiting. You change the lifestyle, like reducing the water intake, alcohol intake, etc., etc. If it is moderate symptoms, 8 to 19, and if the gland size is smaller, less than 50 grams, we believe that it is the dynamic component that is producing the symptoms, you give alpha blockers. If the prostate size is more than 50 grams, then you need to give 5-alpha reductase because 5-alpha reductase is actually going to reduce the size of the prostate. But since the effect of 5-alpha reductase is going to set in after a little while, maybe around 3 to 6 months' time, you want an immediate effect also. So you have a combination of the two, alpha 1 receptor blockers as well as the 5-alpha reductase inhibitor, of which dutasteride is more popular when compared to finasteride. Now, if the patient has symptoms more than 20 or he has complications like retention or urinary tract infection stone, then don't embark on medical management, go directly for surgical intervention. So, the suggested indications of medical management: alpha receptor blockers for moderate symptoms, IPS score of 8 to 19, smaller glands, and precipitated retention. We said precipitated retention is not because of the prostate, it's because of something else. We want to postpone prostate surgery. So in a precipitated retention, you give these alpha blockers, of which celedosin would be very, very fast acting. Young patients, you give this drug and then you remove the catheter, the patients are going to void. If the size of the prostate is more than 50 with moderate symptoms, 5-alpha reductase are going to be effective. But you have to combine with alpha receptors for the symptoms to set in as fast as possible. And when you select alpha blockers, if the patient is highly hypertensive with very mild symptoms of BPH, prazosin is the best drug because the cardiologist would have already started prazosin. You continue with it. It has got some effect on BPH also. It's a non-selective alpha blocker. Prazosin is short-acting, so you have extended release prazosin that is available. Moderate symptoms, 50-50, 50% BP, 50% BPH, doxazosine would be the best. If it is mild BP with more of BPH, then terazosin is the best. Terazosin can have effect both on the static and dynamic components. So that is going to be effective. So mild BP with large BPH, give terazosin. If it is 50-50, you give doxazosine. If more BP and less BPH, give prazosin. If there is no BP component, no hypertension component, give selective, uroselective alpha blockers like alphazosine if it is an young patient because ejaculatory dysfunction is less. Older patient, tamsulosin or celedosin. Patients with cardiovascular diseases and those who require switchover therapy, already on tamsulosin, you want to change the drug, then celedosin is the best because celedosin does not have any effect on the QT interval, does not have any effect on the ECG as well. So the cardiovascular symptoms are going to be less if you use celedosin. So an elderly patient, celedosin would be the best. And if there is a concomitant erectile dysfunction, not ejaculatory dysfunction, erectile dysfunction, add tadalafil. Tadalafil also has an effect on the urinary flow. And if the patient has storage symptoms like bladder symptoms, either you can give naftalpidil, which is a very mild drug straight away, or you can add mirabegron or sulfasalazine to your alpha-1 or uroselective adrenergic receptors. The last slide. There are newer strategies which are available, like the endothelin antagonist. Endothelin is coming in a big way. Endogenous endothelin is there in the prostate, which can cause prostatic contraction. A and B are available. B is there in the epithelium. So if you have some drugs which can prevent this endothelin from acting, then probably that would be a treatment for the future to relieve the symptoms of prostate. I think I am very clear about the medical management, the indications for giving medical management, where you have to give alpha blockers, where you have to give 5 alpha reductase, and where you have to change your medical management into surgery. It all depends on the size of the prostate as well as the amount of symptoms and the phytotherapy and other agents which have been used. Erectile dysfunction, if you have concomitant with your urinary dysfunction, then probably you'll have to combine with 5-alpha PDE5 inhibitors. And when you have storage symptoms like dysuria, frequency extra, you combine with you combine with sulfenacin or mirabegron, which relax the bladder. I think with that, I stop my presentation. I'll be happy to answer any questions. We should have an algorithm for the treatment of patients with BPH because every day a new molecule is coming into the market and every day a new combination is coming into the market. We cannot just play around with these medications for our patients. So judiciously, we should use these medicines so that we get the maximum effect. Thank you very much once again for your patient listening, and I'll be glad to answer any questions from your side. Thank you very much.
So thank you so much for this wonderful presentation. We do have some question if you like to take that up. So the first question is, what are the latest advancement in the medical therapy for managing BPH?
Okay, the latest developments in the medicine, I think in the presentation I said endothelin antagonists, which have not come into the market. The latest ones are the combinations. Like you have the alpha receptor blockers or the PDE5, the 5 alpha reductase inhibitors, getting combined with drugs which can take care of concomitant problems the patient has. So the combination therapy is the latest one that has come into the market.
So next up, we have how does early diagnosis impact long-term prostate health and the quality of life in BPH patients?
Can you please repeat that question? I didn't get the first part.
Sure. The question was, how does early diagnosis impact long-term prostate health and the quality of life in
Okay,
BPH patients?
okay, I get it. This is like preventing BPH. This we said, uh, there is no generalization for preventing BPH. So even if you diagnose BPH, BPH is not a disease. It is part of aging, like your graying of your hairs. Every male person has BPH. It starts at the age of 30 years or so. We are bothered about symptomatic BPH. So even if you diagnose a prostate enlargement at the age of 40 years or 45 years, you cannot prevent this prostate from growing. It will grow. So one generalization that we made was if you can use 5 alpha reductase inhibitors like finasteride or dutasteride for a little while, the growth of prostate can be reduced to a little bit. But that again is skeptical and that again is more theoretical. Nobody uses preventive measures for BPH or improving the prostate health. Once you are symptomatic, there are measures because you do not know how many of them will go for symptoms of BPH. So you don't have to prevent BPH and get a good prostate health. It's not needed and it's not possible also.
So there's one last question. It is, what are the current challenges and unmet needs in the medical optimization of BPH care?
Okay. The challenges would be number one, how to prevent prostate cancer. See, many of these patients will harbor prostate cancer elements in them. So we do not know how many of them are going to turn into prostate cancer. So that is one area where the patients are being mismanaged. Some of the clinicians or the so-called clinicians, what they do is once they detect prostate, they say that you can go in for prostate cancer at any point of time. This is only a general statement that has been made by the person who is treating, because this nobody can say in how many of these prostate enlargement patients can develop prostate cancer in the future. So that is one area that has to be looked into. So probably genetic markers or something will have to be looked into, not PSA alone, because PSA itself may not be. It is specific for prostate cancer, but it is specific, but the sensitivity is not there. If it can be falsely positive as well. So you need markers in these persons with BPH to identify the percentage of people who are going to develop prostate cancer in the future. That may be a challenge that will be coming in. And then probably there should be one drug which should be available which can treat prostate, both the static and the dynamic component. You have large number of combinations which are available now. So probably those will be the challenges for the future.
Thank you so much, sir, for answering all our questions. That's all from our audience. Before concluding, sir, any take-home message from your end?
You want a take-home message?
Yes,
Okay.
sir, for our
Now,
audience.
okay. Now, the take home message is maybe two or three. Number one, BPH is not a disease to be afraid of. It is part of aging. And the symptomatic BPH depends on the amount of symptoms. Again, it is totally unpredictable. It's all tailor made for each person. So you have to see a clinician to identify how much of symptoms you have and how much of prostate growth you have to decide the treatment you require. It may be different from the person around. It may be different from your family members. So each person requires a separate treatment that is required. And judicious use of medical management can postpone surgery for a very long time. Surgery itself has become simplified now. You have minimally invasive surgeries which have come in. The dreaded old surgery is no more in vogue, except in very small number of years. So don't be afraid of BPH. BPH, every male person is going to get. Have medical management, appropriate medical management after appropriate investigation, so that the surgery can be delayed.
Thank you so much, sir, for joining us today. It's a pleasure to have you here, and thank you so much for conducting such wonderful session. Thank
Thank
you,
you
sir.
very much. Thank you. Thank you.